see if it's your turn, Bruce. All right.
These are the O's, starting with the osteoporosis. And we don't have great estimates about the prevalence of osteoporosis in patients with IBD, but it's thought to be somewhere between 14 and 42%. And there are a lot of potential risk factors, including aging, which would be true in the general population as well. Particular to our IBD patients, corticosteroid use. We know that even with one 30-day course of corticosteroids, you see a decrease in loss of bone. Malnutrition, we touched upon this before, but we're particularly talking about maybe low vitamin D. Low BMI, that's a general population risk factor, but of course, many patients with IBD, Crohn's, if they're malnourished, might have a low BMI as well. Malabsorption is contributing. Remember those ADEC vitamins, the fat-soluble ones, calcium malabsorption. Immobilization, if the patient's hospitalized for long periods of time or they're very sick and they're just not moving around a lot. If they had a prior fragility factor, that puts them at risk for another one. A really under-recognized one is hypogonadism, and I have to say that I don't particularly go around checking for testosterone or estrogen levels. I don't know if that's part of your routine practice.
I don't do this routinely. I really do it, case by case. I do have patients actually that come and tell me they saw an endocrinologist and they were evaluated for low testosterone. And I think we're starting to be more and more aware of it. And I wonder if it's something we should check in our patient, maybe reporting low energy level or hair loss or, decreased libido, right? So I agree with you. This is not something that's been on our radar, and maybe it should become on.
For sure. Routine. If we were bone doctors and someone came to us with osteoporosis, we would be checking those. Right. So maybe we can adopt some of that too. And then finally, smoking. We talked about smoking. That's another risk factor for osteoporosis. Another reason to quit if you needed another one. So in the general population, bone mineral density should be performed in women who are 65 and older, and men who are 70 and older. Women a little bit younger than that, and men younger than that if they have risk factors that we mentioned or history of bone fractures. And the ACG and the AGA have recommended DEXA scans in IBD patients who have had steroids for more than 3 months, but as I told you, even 1 month can have an effect on bone density. And screen patients on just the general population guidelines. So I do try to take a family history of osteoporosis in your parents or relatives. That is one of the things I think is very relevant. A little bit about ocular manifestations in patients with IBD. These are much rarer as extraintestinal manifestations of IBD, somewhere between less than 1%, maybe as high as 13%. Often seem to go with concurrent musculoskeletal manifestations, meaning arthralgias, arthritis. And here you see the three classic things that are described, the episcleritis, the uveitis, and scleritis, going from most to least common, I would say. And classically, we say that uveitis among them doesn't parallel the activity of the IBD, so it can happen of its own accord and require treatment independently of the IBD itself. And you see the characteristics here, and of course, what we're most worried about is vision loss, which shouldn't occur with episcleritis, but is a risk for scleritis and uveitis. You see other things going on, headache, tenderness. My bottom line is, if I have a patient with red eye, I don't mess with it. I don't ask about, I do ask about these other things, but I say, you need to see an ophthalmologist right away. But even if they don't present with a red eye, I do recommend that they have an annual ophthalmologic exam, especially if they have history of steroid use in the past, another thing. So turning now to oral diseases in patients with IBD, I hope that we all look in our patients' mouths and think about the pathology that can be there. Think of the gingiva and the teeth and periodontitis. Of course, periodontitis and gingivitis are just common in the general population, but there probably is an association, especially with Crohn's disease, I would say. And people who present to you with oral lesions, first of all, if someone comes to a primary care doctor and they have prominent oral ulcers, that might trigger an evaluation for IBD. It could be a presenting sign or symptom of IBD, but often we'll see bad mouth ulcers that can occur as a precursor to big flare for some patients if that's their pattern. On the other hand, mouth sores are extremely common in the general population, and they just happen, and they don't always mean that it's a flare. I don't know anyone who's doing gingival biopsy unless someone has really rip-roaring inflammation in their mouth, but if you see that, it could be a hint that someone has Crohn's disease. So, the recommendation here is that patients with gingivitis and periodontitis should have dental follow-ups at least 3 times annually, which is about one time more than most of us should be going, probably twice a year. There's a whole spectrum of things that you can see in the mouth in patients with IBD. A lot of these are quite rare. I mean, I don't know how often you've seen metastatic Crohn's disease of the face. I'm not sure I've ever seen that. I certainly have seen, swelling of lips and chylitis, swelling, inflammation at the angles, granulomatous chylitis. Sometimes you'd have to biopsy it to know that. You can see tag-like lesions, cobblestoning, occasionally. I don't see that very often at all. And I would say I've never seen piostomatitis vegetans. It's just extremely rare, but it is said to be highly specific for ulcerative colitis. And you see on the scale of things, moving to the left are things more associated with Crohn's, and moving to the right, things more associated with ulcerative colitis. So I think it's always good to do a complete exam, and looking in the mouth is one thing that I do. I guess the other thing I'm looking for, patient who's on immune suppression, I'm always looking for thrush potentially, so there's yet another reason to look in.
All right, let's talk about mental health and wellness. I think that's very important. And again, that goes back to whose responsibility is it? The gastroenterologist or the primary care in screening for mental health disorder in our patient. And I think it's important to recognize that our patient trusts us at their main doctor when they have inflammatory bowel disease. They're seeing you most of the time for their main issue. And so there is this enough trust in that relationship that you can ask about signs and symptoms of depression and anxiety in the patient. And almost half of our patients with inflammatory bowel disease actually struggle with anxiety and depression. And that incidence is even higher if they have active disease. And that's completely understandable. If you're having abdominal pain and diarrhea and you're running to the bathroom and you have accident and you're avoiding social interaction because you're worried when is the next severe pain is going to happen, or if you are going to have a fecal incontinence, in addition to all potential extraintestinal manifestation that can happen, that is a very debilitating disease, and it does take a toll on patient mental health. But also, we just reviewed the amount of care of patients with IBD need, right? So in addition to their appointment with the gastroenterologist, their colonoscopy, their blood work, their stool test, they also have to do this whole list of health maintenance that we just talked about. So think about your 30-year-old, your 40-year-old, having to really juggle one appointment after the other, from the GI to the dermatologist to the eye doctor. It's a lot. It's a burden. It's a lifelong disease. They know that they need to be involved in the care. There's a lot of doctor's appointment involved. There's anxiety of the flare and of the symptoms, and the anxiety of having potential complication in the future, including colon cancer. So it's really a disease that takes a toll on the mental health of patient, and it's important for us to open the door and discuss that with them, and then refer them to the appropriate person, right? On the other hand, having depression and anxiety actually has a negative effect on the disease itself and disease activity. Patients with Crohn's disease who have depression are at increased risk of having active disease, more severe disease in endoscopy, and more severe disease on histology. So it's really this bidirectional relationship that happened between the mental health and the inflammatory bowel disease that is important to recognize. And this is not unique to Crohn's disease. We see similar finding in patients with ulcerative colitis, where they have more flare when they have a perceived stress, whether this is a physical stress and emotional stress. And so overall, patients with IBD who also have depression are at high risk of active disease, but also complication from the disease, including requiring hospitalization and IBD-related surgery, and relapse of the disease, and less likelihood to be compliant with their medication, and more likely to be relying on narcotic and other medication that mask the symptoms as opposed to treating the underlying disease. I think, again, it's very important for us taking care of patients with IBD, mental health with our patient, and give them and guide them toward appropriate resources.
So I'm going to turn it back to you to talk about special considerations, different populations.
Important. I think you and I, Bruce, maybe I'm a little bit younger than you, but when we started treating...
You're much younger.
Much younger, okay. I love hearing that. But when I started treating patients with inflammatory bowel disease, right, this is a young patient, young population. But now we're seeing an increase in the incidence of inflammatory bowel disease in the older population. One is that those young patients that we were seeing 20, 30 years ago are aging, but also up to 15% new diagnosis of inflammatory bowel disease is in patients older than age 60. So overall, if you look at the entire population, around 1/3 are actually above the age of 60 or 65. And so having a new demographics, and we have to be prepared for taking care of these patients, not just in terms of managing their inflammatory bowel disease, but also in terms of preventive health. So the same issue we discussed in young people, they can be amplified in patients who are older. So bone health, of course, osteoporosis, osteopenia, more common in older patients. Mental health, we know elderly can struggle more with depression and isolation. Nutrition status, smoking, cardiovascular event, ocular health, risk of cancer, especially skin cancer, and as well as other cancer, and the risk of infection, right? Older patients are at higher risk of infection, but mainly complication from infection. The pneumonia that develops in an older patient is a higher risk of leading that patient to the hospital or to the intensive care unit. So similar approach to the young patient, but maybe being even more in tune and more maybe follow up these patients closer for these particular issues. Now, you talked that sometimes you see adolescent and pediatric patient. I sometimes see them around, transitioning from the peds population. And as we know, most of our patients diagnosed with IBD are diagnosed before age 20. And this is really the onset of adolescence. This is really the time where, so many body changes are happening, including the growth spurt and puberty and psychological development. And so you can imagine how a disease like inflammatory bowel disease can really stun all these changes that are happening naturally in the adolescence. So in your patient with IBD diagnosed in young age, you might see different presentations such as growth failure, delayed puberty. So my female teenager don't have their period. My male teenager are still looking like, at 20, they look like they're 14. So these are your cues that some inflammatory process going on. And we talked about depression, anxiety, and how IBD is really has a big burden on the psychosocial life of patients, and that's even more amplified in young people. This is a period of time, if you recall your teenager year or being in high school, this is a time you want to fit in, you want to be cool, you want to be with your friends, you want to become independent from your parents, and here comes a disease that prevents you to do all that. So this is, again, a population that should really be screened for depression and anxiety, and really, taken care in a multidisciplinary approach with a child psychologist. Right. You want to give us a summary?
Yeah. Sure. Well, we've spent the last
45 seconds. You think you can
45
do it for
seconds.
45
We've spent the
seconds?
last
Okay.
hour minus 45 seconds talking about many different things that fall under the category of health maintenance, and something that is really not thought about enough, I think, in the care of our IBD patients. Of course, we think of all the specific therapies for their IBD, but there's so much more that we can do to maintain their health. I think we both agree that health maintenance through preventive care is important in managing patients with IBD because they're going to have these diseases lifelong. They have complications from the disease, from the medications, perhaps. There are lots of things that we can do, making sure their vaccination is up to date, making sure if they're smokers that they quit, making sure that we consider their nutritional needs, and making sure for sure that they're not malnourished, doing appropriate screening for various cancers that they're increased risk at, looking at various other organ systems, skin and eye, mental health, cardiovascular health, and thinking of the patient as a whole, not just as their gut, which is unfortunately probably our tendency all too much. We don't have to do it alone. We can do it with primary care docs, with our ophthalmologists, oncologists if need be, hopefully not very often that. But it takes a team of people to take care of someone with IBD. It's not all on us as gastroenterologists. And the last thing is just to put the patient into the broader social context, the context of a family, the context of their neighborhood and where they live and where they are in life. And all these things really relate to each other in a way that we can elevate the care and the health of our patients with IBD altogether. So it's been a really interesting conversation, I think, and very useful information.
Absolutely, and I agree with you. You have to work with a team, but I do believe it's upon us, because we know the data, to share the recommendation with the patient and their primary care doctor, and that facilitates, and can ensure that our patient get the appropriate health maintenance that they need.
That's right.